Hello, and welcome to this presentation on managing symptoms in the terminal phase. In this session, we will cover pain, delirium, and terminal secretions. Quality end-of-life care is holistic, client-centered, and values quality of life and comfort. With this in mind, let's take a look at pain management. As discussed in previous YouTube sessions, the assessment of pain is multifactorial. Multiple comorbidities, sources of pain, acute, chronic pain, inability to articulate the level of pain, where it is and what makes it better or worse, contributing psychological factors, and health workers' assumptions and misconception can all have a detrimental effect on a pain assessment and the ability to do a good pain assessment. Thorough assessment and regular review of pain is the best strategy in developing a plan of care. The PQRST model of assessment was discussed in more detail in our pain deep dive video, so please refer to that for more information on conducting a good quality pain assessment. Analgesia can be an effective way of managing pain in a variety of different ways, and this is why a good assessment is paramount in deciding an action plan. Opioids are a common analgesic and well known by health professionals and the general public. These block the neurotransmitter or neurotransmitter channels, which stops the pain stimulus being interpreted by the brain. If inflammation has been identified as a factor, anti-inflammatories like ibuprofen and diclofenac and steroids may provide some relief. Neuropathic pain, or pain in the nerves, is often difficult to manage. Antidepressants and anticonvulsants are often used, sometimes as an adjunct to an opiate or another analgesic. Lastly, we can try to change a client's perception or experience of the pain with medication or distraction and other non-pharmacological interventions. With our older patients, the metabolism of analgesics change. You don't need to remember this, but it is just a reminder that an overweight patient or a very thin patient may need a lower dose than normal, and that with age, there are many things that interfere with oral absorption. So if you are struggling to gain control of someone's pain with oral analgesia, an option may be to consider a subcutaneous route. Most of you have seen the WHO pain ladder many times before, but this is just a reminder. A good pain management approach is a stepping stone approach that builds on what we've already started. This slide illustrates the most commonly used analgesics that you may come across on a regular basis when you're caring for your residents. We recommend becoming familiar with the actions and contraindications of these medications so that you can advocate for a rotation for your residents if necessary. This slide illustrates the importance of sufficient and regular pain relief. If a dose is inadequate, suboptimal pain relief is likely. Equally, if the dose frequency is insufficient, your resident may experience periods of unnecessary discomfort throughout their day. Regular scheduling of medication is indicative for optimal pain management. And in cases where residents need frequent breakthrough analgesia, a long-acting analgesic should be considered and reviewed regularly. An adjuvant analgesic refers to a medication that can be used as well as a current analgesia regime in order to enhance pain management for your residents. Be aware of polypharmacy if this plan is indicative for your resident. Rotation of treating doctors and irregular review of medications may lead to unnecessary escalation of the number of analgesics a resident is on, causing other distressing symptoms and side effects. Medications, including pain relief, can be given a number of different routes. It is recommended to start with the least invasive route, like oral medication, before considering other means of administration, as this is often the least distressing for the resident. A note on patches, though. Patches are indicative only for stable pain and are difficult to titrate in a timely manner if your resident's pain is changing. It is also a common source of calculation error when rotation of route occurs. As you can see, a 12 microgram fentanyl patch equates to up to 44 milligrams of oral morphine, which is not a small dose for somebody who may be opiate naive. The most common misconception in terminal care is that everybody who is dying needs to be on a syringe driver or receiving subcutaneous medications. It is important to understand that these medications are used to treat symptoms and not the dying process itself. This once again highlights the importance of an excellent and regular assessment of symptoms in your residents. Just like not all dying people need to be on subcutaneous medications are not just for dying residents. Absorption issues, complex symptoms, and swallowing concerns are all indicative of a review of the route of the medication. When rotating from oral to subcutaneous analgesia, it is important to be aware that the medication is not equivalent. For an explanation as to why this is the case, refer to our other YouTube video on symptom management. As we discussed earlier, your residents may be on a long-acting opiate for pain. It is important to review that the Breakthru is adequate for the background analgesic. A common error we see in clients is a Breakthru dose that is assessed is inadequate based on the background analgesic the client is needing. It would not be a surprise to hear that this resident reports poorly controlled pain in this instance. The way to calculate an appropriate background dose is 1/6 of the total daily dose of analgesia. How do we know if a dose is too high? Opioid toxicity can be identified by involuntary jerks and hallucinations. In severe cases, a resident may have suppressed respiratory rate and pinpoint pupils. The most common causes of toxicity are that the dose is too high, the resident has renal failure and the medication is inappropriate. For example, morphine is contraindicated in clients with an eGFR of under 40, or it's speculated as well a severe infection can affect this. If you identify opiate toxicity, a dose reduction or rotation is indicated. If a resident has been prescribed multiple different opioids, it is difficult to review which has been the most effective and calculate appropriate background and breakthrough doses for your resident, so avoid this if you can. What can we do if pain isn't being managed with our current plan? This is a flag for an overdue reassessment of the pain. Have we correctly identified the source, quality, and timing of the pain? Has the pain changed since the last assessment? Are there any new provoking factors? Pain is a holistic symptom, and as well as a thorough assessment of the pain itself, it is recommended that you also assess other physical, psychological, social, and spiritual factors. Is your resident constipated, breathless, anxious? Is there an infection? Have you identified any existential pain? For more information on spiritual and existential pain, keep a lookout for our spiritual care YouTube video. If you have considered these factors and your client is still has poorly managed pain, consider referring to a specialist palliative care for review. Some general considerations on the use of opioids. Patient and carer education is key. Always start low and titrate up as needed. Consider renal and liver function when choosing the most appropriate analgesic. When starting an opiate, always include an aperient regime for bowel management unless otherwise indicated. And lastly, review the effectiveness of the regime regularly. There are a lot of fears out there about strong pain relief. Many patients, families, and even nurses still have these fears. If your patient or family are refusing to have any stronger pain relief, ask them why. It may well be that they believe that this is only for if you are dying or that you will get addicted. It is important to keep clients and families informed and educated on the care plans in place. Collaborative care planning is highly recommended for optimal management of symptoms. Take-home messages for pain relief. Always explore the pain and believe the patient. Use a meticulous assessment process. Make sure the clients get their analgesia regularly around the clock. Ensure that there is something that you can give them for breakthrough pain. Always attempt to relieve pain and other symptoms. Assess, manage, evaluate, and assess again. And finally, don't be afraid to ask for help from the experts. Now let's look at delirium. We do have a deep dive YouTube video on delirium management, which summarizes the new document that came out from Safer Care Australia. These slides are going to look at terminal delirium only. Keeping residents, families, and carers involved in delirium management will give you the best chance of identifying risk early. And early identification leads to the best outcomes in management. There are 3 types of delirium: hypodelirium, where a client presents as quiet and withdrawn; hyperactive delirium, where a resident presents as agitated or restless; and mixed, where the resident moves between the 2 types. All types can be distressing for the resident and carer. However, hyperactive delirium is often the most likely to make health professionals jump to medications to manage. When managing delirium, much like managing pain, it's important to assess and look at possible causes. Causes could include new or changed medication, infection, constipation, urinary retention, and biochemical abnormalities. When looking at a management approach of delirium, we need to look at when to investigate versus when to symptomatically treat. And this is going to depend on goals of care for the family. You could look at treating easily reversible factors like bowel, bladder, or pain issues, or removing offending drugs, looking at non-pharmacological measures before reaching for pharmacotherapy. And psychosocial support and education for the client and carer and family is always important. First line would be to treat the cause if at all appropriate or possible. Second line would be managing the environment and non-pharmacological measures. And third line would be medications. For non-pharmacological therapies, keeping a stable environment and limiting unnecessary stimulus, having familiar people or employing 24-hour sitters to provide reassurance or regular nursing staff that the person is familiar with, orientation aids, for example, a clock on the wall, the curtains being open during the day and the lights dimmed at night, normalizing a sleep-wake pattern, using patient sense enhancement like glasses or hearing aids if needed, and reducing unnecessary stimulus like loud music or a television. Medications commonly used for delirium, if indicated, are haloperidol, olanzapine, and levomepromazine. Delirium is very common in palliative care. It can be very distressing for patients and the family. It may not even resolve if the person is very ill. There is a need for active screening and ongoing assessment and management until death. An acute delirium in the dying phase should be treated as a medical emergency. Lastly, let's look at secretion management. Secretion management may be part of an illness like motor neuron disease or mouth, throat, and high esophageal cancers, and it is common in the dying phase. Current evidence does not support standard use of antimuscarinic drugs in the treatment of the death rattle. More high-quality studies are needed to give insight into the effects of interventions, both pharmacologic and non-pharmacologic. Until then, care should focus on communication about the symptom with relatives and others involved in the care of these patients regarding the symptom as being normal part of the dying process could contribute to the lowering of distress levels of those involved. Terminal secretions and noisy breathing are sadly also referred to as the death rattle, but it is a normal part of the dying process. It is more common in overhydrated patients, clients with lung and esophageal or gastric cancers, and renal and cardiac failure. Consider if the patient is distressed, or if it's their loved ones that is distressed, or even if it's distressing you. With regards to management, early family education to ensure that they understand that this may happen and is a normal part of the dying process. Avoiding overhydration. Best positioning in order to move secretions around, so slightly elevating the head or helping someone to turn onto one side or the other. Good mouth care. Suctioning is often not useful as it can often stimulate the oral mucosa to make more secretions and can be distressing for the client. And if you're going to use anticholinergic medications, they're most effective when introduced early. The two common medications for secretions that you'll come across are hyoscine butyl bromide, also known as Buscopan, and glycopyrrolate. Due to the price of glycopyrrolate, generally hyoscine butyl bromide is the most commonly used anticholinergic medication for secretions. I'm just going to show you an example of the end-of-life care pathway, of which you, I imagine, would have a version of in your facility. And this is a good example of a way that one may document the plan that has been put in place for somebody and identify needs as they arise, so that you're planning for future care as well. Thank you for listening to this education session, and we'll see you again next time. Take care.